today we have with us Mr. S. Ramakrishnan, Deputy General Manager, SBI Kolkata. Sir, please come on the podium and share a few words with us.
Yeah, friends, good evening to all of you. I had a mild stroke on 13th, that is one day prior to Holi. In the night after I returned from office, I suddenly experienced a lot of weakness and giddiness. Then I thought maybe if I take rest and then get up the next morning, I will be fine. In fact, I felt so weak that I could not even stand to do even basic things. I've had a fear that I would fall down, I will lose my balance. So then in the meantime, when I was talking to my daughter, I found that I am not getting words, even though I am trying to speak in my mother tongue. I was not getting words, and my speech also had become slurred at that time. So since my father had a stroke way back in 2019, I had seen him experiencing this symptom of slurred speech when he had a stroke. So the moment I got slurred speech, I thought this is not due to weakness. So let me get myself admitted. So I went to Woodlands Hospital and then I got myself admitted on 13th night. So I was under the care of Dr. Subdeep Gupta in Woodlands Hospital, and I was administered this blood thinner, and within 2 days, in fact the moment I was administered blood thinner, I was okay. I was my speech had become normal, and under the able guidance and care of Dr. Subdeep Gupta and the entire team at Woodlands Hospital, within 2 days I became okay and I was discharged. Now I am fine. So my learning point in this episode was that the moment with a stroke, because we are absolutely illiterates as far as this medical science is concerned. So the moment we experience any symptom and if we get treatment, I was told by one of the persons one experienced person that this for stroke patients, this blood thinner or whatever is given for treatment, that is required to be given during the golden hour of around 3 hours from the attack. So fortunately, since I experienced all these things at 9 o'clock and I got myself admitted in Woodlands at around 9:45, and I suppose the blood thinner also would have been administered. By around 11 o'clock when I was talking, I found that yes, okay, my my speech had all become okay. Then I was, all the tests were done, and after 2 or 3 days, I was discharged. So, thank you very much for you.
Thank you very much for sharing your experience. So now I would like to call upon Dr. Joydeep Ghosh, who will be presenting his case from Bangalore Institute of Neurosciences. Joydeep, please come to the podium.
Good evening to all the esteemed professors and faculties who have come here this evening to enlighten us about the visual wall imaging and its intricacies, and especially to Raj sir. My presentation will be a crisp recapitulation of all the knowledge that we have gathered here this evening. So without further ado, let's proceed with the presentation. The patient that came to us was a 50-year-old male with no conventional atherosclerotic risk factors, with no history of any long-term drug abuse or no history of any addiction. He presented with an acute onset thunderclap headache with no focal neurological deficit. So let's see how we proceeded to the case. Now, when the imaging was done, you can see here the T2 and the flare images is showing a hyperintensity along the central sulcus. Now what is that? It may probably be a bleed. So we proceeded to do an angiogram of this patient, and what did we find here? You can see here that there is a left MCA, proximal MCA stenosis. It was done on 16 July 2023. The date is important. As we go further towards the case, we will understand. Now, what are the possibilities of this stenosis here? It could be very well a vasculopathy. It could be very well dissection, probably an extraintimal dissection. It could be an atherosclerotic plaque. In vasculopathy, it could be a vasculitis, or it could be RCVS, or it could be, in some cases, moya. But let's see how the disease proceeded. The investigation was done for this patient. All the profiles that we sent for this patient, including the vasculitis profile, the triple serology, HPLC, echo, CSF profile, all were non-contributory. We could find out nothing from that. So we are in a kind of a dilemma that how can we proceed further. Now we did an vessel wall imaging for this patient, and as it was discussed earlier that the vessel wall imaging has various sequences that are done. This is basically a 2D sequence and this is a 3D sequence. Now when we are seeing a 2D sequence, what can be seen here? There is a luminal narrowing. Along with that, there is some enhancement present along the vessel wall. You can see it here more clearly in the 3D. Now what can this be? Now the spatial resolution that is done for vessel wall of MIP thickness around 0.7 millimeter or something showed a short axis view showing some enhancement of MCA. Now this is a grade 1 concentric enhancement. Now as sir have told that there are many types of enhancement and patterns we are seeing in vessel wall. Now let's discuss about the types of enhancement and patterns we usually see in a very basic point of view. Now what are the enhancements that we usually see and how they are measured? There are 3 grades of enhancement: grade 0, grade 1 and grade 2. Grade 0 usually means that there is no enhancement. Grade 1 usually means that there is enhancement which is less than the pituitary stalk, and grade 2 enhancement, which is the strongest enhancement, is usually equal or more than the pituitary stalk. So what is the reference taken here? This is the reference that is taken here depending upon which the enhancement is given. Now let's see about the patterns of enhancement. We know that there are largely 2 basic kinds of enhancement pattern. One is the concentric pattern and one is the eccentric pattern. Now this is a grade 1 concentric enhancement, as we can see here. As we go further, we can see a grade 2 or a stronger concentric enhancement, and in various diseases, as I will go further, we will discuss about that. This is an eccentric enhancement we can see here. Now how usually we measure the patterns of enhancement in vessel wall? You can see here, if we consider this the inner wall of enhancement and this is the outer wall of enhancement, A represents the thinnest width of enhancement and B represents the thickest width of enhancement. How is it measured is that when A by B is greater than 50%, it usually means a concentric enhancement, whereas A by B less than 50% means an eccentric enhancement. Now why these are important? Because in various diseases we find various vessel wall imaging which can give various types of enhancement and it can help us to differentiate a disease. For example, in case of an ICAD, you can see here the top MRI image is showing a tight stenosis along the right MCA. Now if we look at the proton density imaging, you can see there is some eccentric enhancement present, and this is the T1 post contrast image which shows an eccentric enhancement which goes with atherosclerotic plaque. Now as sir has told us, there are many patterns of concentric enhancement. It could be due to atherosclerotic plaque, it could be due to dissection, and it will be discussed in this presentation only. Now let's see another disease pattern. Here you can see this is a patient with moya moya. This is a patient of moya moya syndrome. I am telling you why, because as you can see, this patient is showing some eccentric enhancement in his terminal right ICA, and there is very few enhancement present in the left ICA. Now after 1 year, when the vessel wall imaging was done for this patient, you can see that there is almost a concentric enhancement present in both terminal ICA. Now as we can remember from previous discussion that moya moya usually have negative remodeling and they don't usually show enhancement pattern, but in case of moya moya syndrome, the enhancement pattern can be usually grade 1 or grade 2, but in normal cases of moya moya we usually find a grade 1 enhancement, which is a specification for a moya moya disease. Now let's discuss a case of CNS vasculitis, and as you can see here, the top MRI image is showing there is a stenosis present at the right terminal ICA. Now when we did a vessel wall imaging, we saw a grade 2 concentric enhancement of the terminal ICA. Usually the pathogenesis is the leakage of the contrast in the vasovasorum. The vasovasorum is affected by vasculitis and it results in this vasculitis pattern. Now if we see a 3D image, a T1 pre-contrast is usually showing a luminal narrowing. Now a post-contrast image is showing a grade 2 concentric enhancement. These are usually features of vasculitis, but vasculitis may very well be present as an eccentric enhancement as well. Now let's talk about RCVS. This is a T1 pre-contrast image showing a luminal narrowing, and when we did a post-contrast image, there is very slight enhancement present, which is actually a feature of RCBS. It usually presents with no enhancement or a grade 1 concentric enhancement. A short axis view will give you more idea about how the enhancement looks like. Now let's discuss a case of post-infective focal arteriopathy. Now how is it different from vasculitis, or it is different from RCVS? As you can see here, the top image is almost identical and showing a severe stenosis at the rate of terminal ICA, but you can see here in the T2 image there is some enhancement present, which helps us to differentiate from vasculitis. In T2 of post-infective focal arteriopathy, there is some concentric enhancement present, and in T1 post-contrast we can find strong enhancement. This enhancement usually remains for weeks to months at end, and even after doing a repeat vessel wall, we can find this enhancement as well. Now let's do a comparative analysis of all the eccentric vessel wall enhancement. As you can see here, atherosclerosis and dissection, as told previously, can present mean maximum cases with eccentric enhancement. Now when we are dealing with atherosclerosis, we would have a lipid-rich core, which will be hypointense in T2, and in fibrous plaque there will be T2 hyperintense. However, in case of dissection, we can find intraplaque hemorrhage as well, which will have T1 pre-contrast enhancement present in the pre-contrast image only. Now when we are discussing about atherosclerosis and dissection, how does the MR vessel wall image helps us? The T2 MR vessel wall image helps us in this case, as it can differentiate from lipid-rich core to a fibrous plaque. Now when we are talking about concentric enhancement, there are usually 3 diseases that come to our mind: vasculitis, moya, and RCVS. In vasculitis, all 3 layers get equal enhancement because of contrast leakage, and usually they are concentric. Occasionally, in some cases, vasculitis may present with eccentric enhancement, where T2 helps us because T2 shows juxtaluminal hyperintensity in case of ICAD or an atherosclerotic plaque, which is not present in case of a vasculitis. In moya, where the pathogenesis is negative remodeling, we usually find a concentric enhancement with very grade 1 concentric enhancement. In case of moya syndrome only, we get grade 2 concentric enhancement. And RCVS usually presents with no or very less enhancement. Now, as we are discussing about the concentric enhancement in vessel wall MRI, there are various diagnoses that comes to our mind. Now, how does the vessel wall helps in this case? Now, angiogram was done, and the angiogram done after 3 months and also after a year, when the patient was given conservative treatment only. As you can see here, there is no luminal narrowing present, and the M1 has retained its previous shape with a conservative treatment only. Now, what could be the diagnosis? Probably this was a case of RCVS, and RCVS usually presents with sulcal bleed or convexity SH. The reason for presentation of a convexity bleed is that there is severe vasoconstriction and endothelial dysfunction of small arteries, of fragile arteries, which usually have reperfusion injury, and they rupture and give rise to convexity bleed. So, in most cases we see that there is complete resolution, around 45.7% cases, 18.6% case show partial resolution, and there is no change in around 35.7% case. Maximum cases of RCVS present with concentric enhancement, where a very few, around 27%, present with eccentric enhancement. Now, we got various kinds of diseases with various different treatment modalities, which may present in an identical manner. Now, vessel wall imaging is a utmost and important modality which is helping us nowadays to differentiate these diseases who have various other treatment modalities, so that we can go further with the treatment of these cases and determine which of them require immunomodulators and which of them require conservative management. So, and in near future, vessel wall image may be considered an optimum surrogate for brain biopsy as well. Thank you.
So, for the next case, I will call Dr. Madhurima Raj from Bangalore Institute of Neurosciences to present her case.
Good evening, everyone. Today, my presentation is A Tale of a Bleeding Brain. Summary of the case: a 38-year-old male smoker presented with history of recurrent episode of seizure and focal neurological deficit since 2020. First attack on 9 September 2020, there was history of loss of consciousness followed by left-sided hemiparesis. That lasts for 1 month, then patient gradually improved with physiotherapy. On brain imaging, there was right parietal ICH. Second attack on January 2022, patient attended ER with left-sided weakness. On brain imaging, there was right basal ganglia ICH. Third attack on November 2023, there was focal seizure with secondary generalization. Brain imaging shows left parietal ICH. There was mild headache for last 4 years, but there is no history of any cognitive dysfunction, any other cranial nerve involvement, fever, night sweat, rash, arthralgia, orogenital ulcer. Patient was stable, GCS was 15/15, left-sided power is 4+/5, right side 5/5. These are the CT scans that done on consecutive year 2020, 2022 and 2023. Then we have done MR angio for the patient, and that was MR angio head and neck, that was normal, and MRV is also normal in this case. We have done some routine investigation. Complete blood count was normal, PTINR was normal, renal function test, liver function test was normal. We have done ANA, NA profile, ANCA, that was negative. CSF was done, as this is a case of recurrent ICH. CSF cell was normal, protein was, on 2 occasions it was more than 45, that is 74. We have done whole exome sequencing and it came out to be congenital dysfibrinogenemia. As the patient's CSF protein was not corroborative with the genetic report, we have done one special test, that is thromboelastography, that didn't suggest any abnormal fibrinogen function. Then we have proceeded for digital subtraction angiography to check for any abnormality of vessel wall. This is digital subtraction angiography of left side showing arterial phase and venous phase, that is normal. This is DSA of right ICS showing arterial phase, that is normal. But in the venous phase you can see there is puddling of, I am showing the video. In the venous phase there is puddling of contrast and also beading over vein, that we can see it's suggestive of venulitis. Done MRI vessel wall for the patient to check for any arterial wall involvement, but there is no contrast enhancement over the large artery. This is one vessel wall imaging, that is normal in this case. So conclusion of my case, DSA suggestive of venulitis. Patient was started on IV methylprednisolone 1 gram for 5 days followed by oral steroid. After that myclophenolate mofetil 500 BD has been started and there is no further event after immunotherapy. Thank you.